Good day, and thank you for joining us for this webcast. My name is Stacy Humphrey, and I'm joined by George Deely, Vice President of Healthcare Applications Development at Dimensional Insight. We'll be your hosts today as we discuss how to use business intelligence and analytics to automate ongoing physician practice evaluation reporting, and how to leverage that data and the resulting insights to constructively engage with and align physicians. Just a couple of housekeeping points before we get started. If you have a question during the webinar, please type your question into the GoToWebinar console on the lower right of your screen. We'll answer it during the Q&A session. If we do run out of time, we'll get back to you via email to answer your question. So let's get going. We will start off by looking at some of the drivers of the healthcare economy and how they're affecting hospitals and physicians. We'll examine how these dynamics come squarely into play in the physician performance evaluation and management space. Next, we'll give an overview of the DI Physician Performance Advisor Analytics application and do a demo. And we'll wrap it up with a Q&A session. Multiple forces are pushing hospitals and physicians to provide better care at lower costs. Competition is one of those forces. The Department of Health and Human Services now makes available to the public various quality measures on a hospital's performance. Patients now have access to standardized ratings to assist them in choosing where to go for care. The government is another factor. Via recent legislation, most notably the High-Tech and Affordable Care Acts, the federal government is weighing in on healthcare costs and quality. Costs, currently on an unsustainable growth path, is the very visible 800-pound gorilla in the room. Net-net, we are heading down the road of change. Changing business models that will shift reimbursements from volume to value-based and put revenues at risk. New delivery mechanisms such as accountable care organizations, global payments, and value-based purchasing will now directly tie outcomes to revenues. These changes will impact both the physician and the hospital. While the hospital is responsible for care provided to the patient in their facility, it's the physician who actually manages the care of the patient, and so drives the hospital costs incurred for that patient's care. Both will be dependent on each other to survive and to thrive in the new healthcare landscape. This relationship will become even more important given the trend towards accountable care organizations. While the Medicare Shared Savings Program officially began at the start of this year, there are already 2.4 million patients being served by physicians, hospitals, and other healthcare groups working together and taking responsibility for the quality of care, in return for the opportunity to share in the savings realized through improved care. At the core of improving care is aligning physician behavior with hospital performance goals. And that starts with information, objective and credible information about the physician's performance. On the hospital side, there's the need to collect a wide range of information from a large number of sources to assemble the physician profiles. That's not an easy process. It can be very labor and time-intensive to do. On the physician side, there's lingering reservation about having to be measured, skepticism about the validity and accuracy of the data being used for measurement, and in many cases limited access into his or her performance relative to benchmarks or peers. One of the biggest opportunities to improve both efficiency and care quality is reducing variations in care. To do this requires visibility into the physician's performance across care settings and categories. It also requires using relevant benchmark information, both external and internal. You also need to be able to examine the data from multiple perspectives, by physician, practice, specialty, and facility, so as to be able to pinpoint problems as well as detect patterns such as best practices. Access to the underlying data is crucial for providing details and engaging in a constructive dialogue with the physician. Whether you're going to become an ACO or just employ accountable care practices, you're going to need to measure, monitor, and manage at a patient and population level in order to be in a position to reduce overall costs and drive improvements in care. That's where business intelligence and analytics really come into play. So George, how does dimensional insight help healthcare providers deal with these challenges?
Well, Stacy, the starting point for addressing these challenges is capturing information and sharing it among the parties that are involved in both providing and consuming healthcare. First, we have patients. Most of the relevant information in healthcare originates with the patient. Information about the patient, demographic characteristics, clinical observations such as height and weight, results of various tests, and increasingly feedback on their experience of care. Then there are the physicians who are responsible for managing the care of patients. They contribute information on their observations, interpretations of tests, and diagnoses, as well as the details of the care they prescribe. The hospital, or other settings of care, provide the facilities where care is delivered, and consequently are in a position to collect vast amounts of information on patients while they are under their care. So if these three groups to function together cohesively, there needs to be good sharing of information. Now, as an industry, we've begun the process of streamlining the flow of information, and that will get better over time. But we can work with what we have to get started today. Now, the most comprehensive source of information today tends to be the hospital. So using the hospital information to improve alignment between hospitals and physicians to increase quality and reduce cost of care to patients is a big step in the right direction. A hospital collects many different types of information across the various settings of care that help to provide visibility into physician practice patterns. Now, ideally, you'd like a composite of this information as it relates to individual physician activity. But one of the biggest challenges here is around the credibility of the information. A physician will reasonably ask, "How can I trust your data?" And if it's aggregated data, it would take a gigantic leap of faith to trust it. However, if you can show the physician how this information relates to his or her individual patient interactions at a detailed level, that can go a long way toward overcoming this issue. But creating the data necessary to do this and provide this level of visibility comes with its own challenges. Lots of data and lots of connections among that data. Fortunately, technology can help, and specifically analytics technology. At Dimensional Insight, we've been applying analytics technology to healthcare for more than 10 years. We've used our experience to develop an architecture that's specifically designed for healthcare information. The foundation is the Diver Solution Business Intelligence Platform, recognized as best in class for the last 3 years. The Diver solution has proven quite adept at helping provider organizations to manage and integrate the various types of healthcare information, including financial, operational, and clinical. We've layered a healthcare-specific framework on the platform that represents data in ways that are well organized, comprehensible to users, and convenient for analysis and reporting. Finally, we're using that framework to develop a family of applications that apply analytics to common problems. These include healthcare-specific performance dashboards, meaningful use compliance reporting, surgical service line performance analysis, and the physician performance advisor. The DIPPA product, as we call it for short, is designed to consolidate information from a variety of data sources within a healthcare system's information environment to provide a comprehensive view of physician performance at both the individual and aggregate level. This includes information on utilization, outcomes, patient satisfaction, and measures of quality and safety, all based on patient encounters with which a physician has provided care. To maximize opportunities to respond to the information while it's still fresh and actionable, the data can be updated at the frequency that makes the most sense. For example, patient encounter data becomes available daily and provides the basis for utilization and outcomes measures. Patient satisfaction surveys and quality measures, on the other hand, become available less frequently, typically monthly or quarterly. Now, this information is presented in two ways. First, to physicians, for them to monitor their own performance on a self-service basis. And secondly, for hospitals to identify opportunities to improve and pinpoint the physicians who are in the best position to contribute to those improvements. So how is performance defined, and how does it relate to opportunity? Well, they're both related to the difference between expected and actual values. The expected value, such as length of stay, for example, is determined at a patient encounter level based on a benchmark that a hospital system selects, typically based on the performance of a peer group of hospitals. So that represents a fairly objective measure that can be traced right down to the individual physician-patient encounter. Now, combining this encounter information together provides the basis for aggregate measures, say for specialty or an entire hospital. So that allows a physician to understand their aggregate performance levels in terms of individual patient encounters with which they've been involved. Now, the advantages of DIPPA to hospitals include more efficiently complying with ongoing physician performance evaluation, or OPPE, reporting frequencies required by the Joint Commission for Hospital Accreditation. One of our larger hospital customers found that they were able to reduce the amount of labor involved in OPPE reporting by over 1,000 hours per year. And perhaps even more significantly, hospitals can analyze data from PPA to understand how physician practice patterns are affecting overall hospital performance. Now, at the physician level, the benefits take the form of visibility into individual practice patterns, including utilization, outcomes, and patient satisfaction, and opportunities for physicians to compare themselves both to overall benchmarks as well as the performance of their own peers within their healthcare system. In both cases, the key to successful communication and alignment is objective, reliable, and sufficiently detailed information. Now, the user communities that DIPPA serves are, first, and probably most importantly, physicians, who can better understand their individual practice patterns and performance. Second, hospital and practice physician leadership, who play a key role in alignment between the physician community and the hospital and are responsible for that communication. Quality and safety managers, who can better understand patterns around quality and safety compliance and get to the details understanding those patterns at the patient-physician encounter level. And finally, hospital administration can use aggregate information to both understand their current performance levels better, as well as plan based on expected improvements, and then track and monitor progress against those improvement initiatives. So now let's take a look at how DIPPA actually works in practice. Okay, so let's begin by looking at DIPPA from the perspective of a member of hospital physician leadership, such as the medical director. We're going to begin by looking at the opportunity perspective, which allows us to compare the hospitals in our health system. And in our demonstration example, we have 4 of varying sizes, as you can see in the differences between their case volumes. So what is opportunity? It's basically the difference between the actual or observed value and a threshold or a benchmark that we set, which is typically based on a peer group comparison. For example, the top quartile of performance of peer peer group hospitals. So that allows us to set a target, perhaps a very aggressive target, for performance improvement. Opportunity allows us to understand what the potential, the extent of that improvement would be. So we're going to begin by looking at our two primary measures of utilization, specifically utilization of inpatient resources. So we can see that there is a difference in the caseload amongst these four hospitals, and we would expect that the largest hospital would be in a position to contribute the most significantly to both length of stay and cost reduction. However, each of these hospitals can play a role in performance improvement. Now, let's start, just to use an example, with one of the hospitals in the Metropolitan, and we can look at the potential contributions to performance improvement by going down to either the specialty level or right down to the physician level. So let's begin by looking at all of the physicians for the entire hospital system, and we can see that for length of stay and cost reduction opportunity, it's the physicians with the highest case volumes who have the biggest opportunity to contribute to performance improvement. Dr. Swanson and Dr. Barnes have approximately the same number of cases, and incidentally, this is for our chosen time frame, which is the most recent 6 months. But Dr. Cole, although she doesn't have as many cases, she still has a fairly significant opportunity to reduce length of stay. Now, in addition to opportunity, we have another perspective on performance called analysis. And analysis looks at the weighted average performance by aggregating information for an individual physician's patient population. So, continuing to focus on cost, we see that in terms of the difference between the expected and the actual value, and we refer to that as the index, it's actually the smallest hospital that has a pretty significant opportunity to improve on their average cost per patient. So let's take a closer look at that, and this time we'll go to specialty first to try to understand where the opportunity is concentrated in terms of groups of physicians. And not surprisingly, it's the internal medicine physicians who represent most of the patient encounters for the attending role. So for this analysis, we have selected the attending relationship between physician and patient encounters. So for cost, we can see that there's a significant opportunity to improve amongst a variety of different practices, but since the internal medicine group does have an kind of overwhelming majority of the cases, we're going to look at the physicians who comprise that group. So in terms of cost, let's sort this by index, and it's pretty clear that in terms of the biggest opportunity to improve, it's Dr. Ortega, but he doesn't have a very big caseload. And if we look at the physicians who do have the highest caseload, Dr. Stark kind of rises up to the top because he does have the biggest discrepancy between observed and expected values, both for average cost as well as length of stay. Now, there's probably a basis just from the analysis that we've done so far to have a conversation with Dr. Stark to better understand his current practice patterns and where he might be able to improve. And during that conversation, we may want to take this down to information on individual encounters, but we'll save that until we actually get to our meeting with Dr. Stark. Now, the third perspective that the administrative review side of the application provides is called practice patterns, and it allows two similar practices to be compared to one another for performance purposes. So we've looked at two groups so far, Metropolitan and Powers, and we're going to look specifically at the internal medicine group for both of those, so that we can do as much as possible an apples-to-apples comparison. So we've chosen Powers, internal medicine, and specifically the attending physician role for the most recent 6 months. And we can very quickly get an idea of the differences and similarities in the practice populations between the two groups. So we see the metropolitan physicians do see more patients. They have a higher caseload, 3,500 versus 2,200 for Powers. We can also see that there is a difference in the patient population. The case mix is higher at Metropolitan, 1.43 compared to 1.14 at Powers, and by other measures of acuity, severity of illness, and risk of mortality, there is a higher acuity level of the patient population at Metropolitan as well. But more significantly, we can jump over to objective comparison of performance. And kind of sticking with our analysis of average cost per case, we see that the Metropolitan group has a higher cost per case than the physicians over at Powers. So 8,500 compared to about 6,800. So it could be very tempting to jump to the conclusion that the Powers physicians are actually doing a better job of managing costs. However, if we look at the observed value versus the expected value at Metropolitan, we see it's actually closer. So the index is 1.04 compared to 1.08 for Powers, implying that the Metropolitan physicians are actually doing a better job of managing costs despite their higher cost per case. So there's two things we can take out of this. One is that the Metropolitan physicians are actually doing a pretty good job, and there is an opportunity for the Powers physicians to improve, and also that the Powers physicians might want to spend some time working with the Powers physicians to the Metropolitan physicians to understand their practice patterns, to see if there might be some things that they can be doing to help manage their costs better. Okay, so let's shift gears and go over to the physician self-service perspective. And this is where an individual physician would look at his or her individual performance from a self-service view. So they essentially have access to this information anytime that they need it. Now, we're still looking from the perspective of the medical director. Now, the medical director has access to all physicians and might use this information to prepare for a meeting, a conversation with one of the physicians that he has oversight over. So we looked at Dr. Stark. As medical director, I may want to go in and look at this information in advance of our meeting to be prepared for it. So we're going to continue to look at this last 6 months of activity with the attending role. And there's a variety of different things that I can see. Now this is the information that a physician would see as they logged in as themselves. It would bring them directly to this information. So I can see what the case volume history is over the last 6 months compared to the 6-month period before that. It looks like case volume is down slightly. Most of Dr. Stark's activity is in the attending role. We can see when he's next due for reappointment. There's a variety of different perspectives that we have on this information, but the most significant one relates Dr. Stark's activity to performance using the expected and benchmark values. So in keeping with our example of cost, we can look at measures of utilization focusing on cost. However, we can also extend this analysis to the other categories of information: outcomes, quality measures, patient satisfaction, patient safety, and risk management. Now for cost, these are the same numbers that we saw in the administrative review section, but we're going to want to take this down to the next level of detail. And there's a few different ways we can look at the information on a month-to-month level over the last 24 months. Now, how is Dr. Stark doing with respect to expected cost? And it looks like in the most recent months he's actually doing pretty well. There was a spike up 3 months ago where his cost was much higher than the index, and that will kind of help us understand in terms of chronology. Is he improving or is he not improving? The lighter color is the prior 12-month period. The darker bars represent the most current period. So we can also we can look at improvement year over year here as well. But at a really specific level, we can take this right down to the patient encounter level. So far we've really looked at aggregate information. That aggregate information is based on individual patient encounters. Now, on the way down to individual patient encounters, we can make some observations here in terms of how Dr. Stark compares to his peers in the internal medicine group at Powers. And it looks like even though his length of stay is the same as the peer group, he was actually expected to do a little bit better based on his patient population. So his index is not quite as good as the overall peer group. So the real substance of both a physician's evaluation of their own performance as well as an interaction between a medical director and a physician really comes down to individual patient encounters. And this is a list of all 527 encounters for which Dr. Stark was the attending physician. And we can sort this information across any of these columns so we can get an understanding of the high-cost encounters, as well as case mix as a measure of acuity. But we might want to focus, since we're looking at average cost per case, on some of the high-cost encounters. And we have information associated with those cases. So here's an example where the severity of illness and risk of mortality weren't at the highest level, but it's still it's an extremely expensive encounter. We might want to understand a little bit more about what was going on there, in a dialogue with Dr. Stark. So here we get a little bit more information about this individual patient encounter. We can see the other physicians that were involved in a consulting capacity and the various types of consults that were done, how the resources were distributed across the treatment for this case, just to get some additional insight in terms of what happened during this case. We can see what type of case it was. We can see it was a septicemia case that also involved a colonoscopy. This is not intended to take the place of the very detailed information in an EMR, but it's intended to be a bridge to at least get a high-level understanding of the encounter, and then the physician and the medical director could go to the EMR to get additional detailed information to understand this case and the treatment patterns at a very specific level. So a very quick overview of the performance advisor. Obviously there's much more there than we have time to look at here, and we'd be delighted to go into more detail with you in an individual demonstration with your organization. So to summarize, alignment between physicians and hospitals is central to improving healthcare delivery, and objective, timely, and credible data provides a critical conduit for the communication essential to that alignment. The DI Physician Performance Advisor solution facilitates hospital-physician communication by presenting information in ways that are intuitive and actionable. In addition, it helps hospitals more efficiently comply with OPPE reporting requirements and provides hospital administration with a data-driven approach to performance assessment and monitoring.
That wraps up the formal part of the presentation, so we're now going to turn and answer the questions that have come in. My first question is from Ron, and he asks, are there specific EHR or revenue cycle systems that this application works with?
Thanks, Ron. That's an excellent question. The answer would be no. We've designed the DI Physician Performance Advisor application so that it can work with essentially any system that can provide the information required for the various data realms. So, for example, utilization data tends to come from the EHR system. Cost data would come from the revenue cycle system. Patient surveys and quality metrics, in many cases, come from external data feeds. So we provide specific data extracts for each of the data sets necessary to building this composite physician view. And as long as that information is in an electronic format, and in the case of data that's associated with a particular patient encounter, as long as it has an encounter identifier, we're able to process that information.
The next question is from Carrie. She asks, I'm not very familiar with OPPE. Could you talk more about that?
Yes, the Joint Commission requires hospitals, for purposes of accreditation, to define the process that they use to communicate performance-oriented information to physicians. And one aspect of the requirement is that the reporting frequency needs to be more often than once a year. In fact, one of the reasons that we decided to develop the DIPPA application is that even at an annual level of frequency, the amount of time, effort, and labor necessary to manually compile this information is overwhelming. If you go to a frequency of, let's say, 6 months or 3 months, that compounds the problem. At the same time, getting that information out to physicians so that they can use it and understand their performance levels is critical. So self-service reporting kind of takes that requirement to probably the point where it was intended, and that was to make performance information available to physicians on an interval that's most useful in terms of incorporating that information into their actual practice.
There's a question here from Michael. He says, I understand that electronic reporting makes economic sense, but sometimes having a paper copy is important. Can you do that with this physician application?
Yes. One of the initial design considerations was to make summary level performance information available via printed reports. Now, we fully expect that both physicians and hospitals would use the electronic self-service interface for the most part. However, there will be situations where a paper copy is in some cases perhaps required, but if not required, at least convenient for a particular situation. So, for example, in a meeting between a member of physician leadership, such as a medical director and a affiliated physician, the discussion around performance levels might be facilitated through that paper copy, where the physician takes that paper copy, maybe with some notes that they jotted down during the meeting, back with them, and then of course can refer to the self-service interface. But just having a record of that interaction is something that may be useful.
We've got time for one more question. That question is from Peggy. How much flexibility is there in customizing or adapting metrics for our organization?
Hi, Peggy. That's a great question. We fully expect hospitals to ask us to tailor metrics to their specific requirements, and in some cases, perhaps even add metrics that are relevant to the way that they measure physician performance. An example of that would be in the outcomes area. So the standard measure of readmissions is the 30 30-day all-cause readmission. But a hospital might look at other measures of readmission, such as a 7-day or a 3-day readmission for a variety of different purposes. And maybe even more specifically, they might want to subclassify those by disease type. So let's say, for example, 7-day readmissions where the primary diagnosis for the index or the originating admission was congestive heart failure. So you've got a hybrid readmission measure that the hospital might find much more useful than the standard 30-day all-cause readmission. That's exactly the type of tailoring that we would expect to do to these metrics to help a hospital be as precise as they can possibly be with respect to useful performance measurement.
This concludes today's webinar. George and I would like to thank you for attending and invite you to check out the additional resources that are available on our website. We'd also like to encourage you to contact us if you'd like to learn more about DI, Physician Performance Advisor, or set up an in-depth demo for your organization.